Hi, everybody. I'm Al Rochelle as we continue our conversations about dysautonomias, and we're going to talk specifically about syncope, which is a fainting, and we'll define that a little more closely. But joining me right now is Dr. Julian Stewart. And Dr. Stewart, thank you for being here with us.
Well, you're welcome.
Give me a little bit of your background, would you?
Well, I went to college at Cornell University. I did an MD, PhD at the University of Chicago, followed by residency in New York and fellowship, both at NYU and then again at Cornell. And right now I'm situated, and have been for a while, at a place called New York Medical College, which is somewhat north of the city. It's interesting. I was actually trained as a pediatric cardiologist, and there are a few others here. In fact, most people who, in the past at least, evaluated syncope were cardiologists with a dearth of neurology kinds of folks. So there's a type of test called tilt table testing that's become less and less popular for no good reason. And I was given the job to do that, and it was in the past used pretty much exclusively to look for a form of syncope. But then I saw other things happening and got interested in the phenomena, which were probably mostly POTS. And I'll mention a word or two about that too. But
yeah. So I guess we start with the basic definition. Syncope. Fainting, is that what it basically is?
Yes. Syncope has a really precise diagnosis, which is loss of consciousness and postural tone. You have to fall down. And it has to be of rapid onset. It has to terminate, it has to be relatively short. It has to involve loss of brain blood flow, very specifically, which distinguishes it from seizures and many other things. And it has to resolve spontaneously, and that's a real critical one. Syncope goes away, and if it stays longer, then I would call it a coma. Usually it's a matter of seconds or something like that, at least the kind I deal with.
Right. So the tilt table, we've talked a lot about with a lot of the doctors. So I didn't realize that there aren't, so some people don't like to use tilt table, they don't believe in it, or what?
I think you have to be a little careful. What it really does, it distinguishes it from standing, is that it really doesn't let you move your feet around a lot. And our defense, or one of our primary defenses against fainting, and let me point out now that we can all faint. I can make you faint, but you probably wouldn't want to. It's a normal reflex. I think many people now believe it's the hemorrhage reflex, and that it actually has a considerable amount of benefit under certain circumstances, like hemorrhage. In any case, the tilt table was actually used by NASA and other groups much before this, and but all it does is prevent one kind of compensation, and so.
But as a diagnostic tool, it can still be used,
Well, in kids, it's a little funny, but we've developed a certain type of expertise that it transcends the deficiencies of the tilt table. So, roughly speaking, 1 in 3 kids who have never fainted, the volunteers in our studies, will faint on the tilt table, and it's indistinguishable from a faint in a fainter, and only 2 out of 3 fainters will faint in a given session. So it's not a great test, but we instrument them with things to measure the way blood flows, and over the course of research, we found that in young people, at the very least, and this is well published now, they have a fall off in their ability to contract down their blood vessels, which allows actually blood to flow too rapidly and unload the heart, and then the blood pressure falls along with that. But it's not what most people think. And if that occurs, we can see the trend in the resistance to blood flow way before they actually faint. And we've had people who, among the 2 out of 2 out of 3
right.
faints.
Yeah,
Fainters faint. Well, the 1 in 3 fainter who doesn't faint, we can see this trend and treat them on that basis.
So you can treat them. So when do you know that it's
we haven't gotten into fainting, bad fainting and good fainting.
Okay, keep going then.
All right, so the fainting, that is what I told you as the definition, is roughly partitioned into 3 parts. One is cardiogenic fainting, meaning your heart's not working very well.
Okay.
Like it stops. If it stops, you're going to lose consciousness, but remember spontaneous recovery.
Yeah.
So in young people, that's relatively uncommon, but we've all seen it. The second is a type of usually autonomic disease, or it can be a form of dehydration called orthostatic hypotension. And that means when you stand up, your blood pressure relentlessly falls off. And this happens in people with adults with severe autonomic disease and others. And as it falls off, if you don't lie down, you'll pass out.
Yeah.
And the last group broadly is called reflex syncope. And that includes some situations that can cause fainting, which are relatively uncommon. One of them is hair grooming syncope and
oh my gosh,
adolescent stretch syncope. I don't think adults can do the maneuver. It's a peculiarity, and a bunch of other things that are more particular to adults. And then the large majority of fainting falls under the category of vasovagal syncope, and that's what we've been talking about when you were asking me these questions.
Right? Yeah.
So most the diagnosis isn't so much made by a tilt table. It's actually a characteristic history taking that you get.
Now we've heard that a lot from other doctors too. A very good history.
Well, this one's very good, and there are symptoms that usually precede a vasovagal faint, and we call that a prodrome. Okay. And may distinguish it from POTS, by the way, but I guess we can't do that without pictures.
Yeah.
And then there are symptoms that follow vasovagal syncope, notably headache and fatigue, great fatigue.
So the patients that you see, where are they in this process of determining whether the faintings are benign or whether they're a real problem?
Well, fainting can be infrequent, or let's say it's the first time. Typically, it occurs during or after puberty, although it can occur, the youngest I've seen is a 2-year-old with the same physiology. But mostly they're teenagers, and at that age, about twice as many girls as boys, but the boys catch up later on.
Oh, they do. Yeah.
Well, what's really interesting, one aspect that's interesting is that the age distribution is bimodal. What I mean by that is that the age of first faint is 15, let's say, on the average. It goes away, it seems to, in the 20s or 30s. Not everybody, but then it comes back again later on. And so bimodal.
Oh, yeah, okay. Sure.
It's usually 50s and 60s, where it may be confounded by things like blood pressure medicines and so forth. So there's a lot of interest in that.
When do you intervene and actually then step in and try to figure out ways of treating pediatric syncope?
Well, if they have cardiogenic syncope, they need to have it fixed. You know, they can have a rhythm problem that needs to be specifically treated. Okay. They may need a pacemaker and so forth and so on, but that's not the main group that you're talking about. Single or infrequent vasovagal syncope, you've diagnosed it by history and by standing or tilt table testing or whatever. I just tell them, it's amazing. They have to recognize, they don't recognize it's coming on because they've never experienced it before. And so often the first faint is injurious, shall we say.
Oh, yeah, sure.
And then they learn if they have any sense.
I've got a signal I'm going to faint.
And then what I tell them to do most of the time is either lie down or squat. Sitting can work, but not
can
always.
Any of it just go away naturally?
Well, eventually it goes, oh, you mean can you remain upright?
Yeah, but I mean, let's say you've had some of these syncopes.
Well,
it gets complicated.
No, not exactly. Vasovagal syncope may be I don't know what happens if you leave someone indefinitely upright.
Okay.
And I'm not sure you want to know
Yeah,
either.
yeah.
But there's a type that's often mistaken for this or for other forms of orthostatic intolerance, in which typically someone stands from a lying down position, where blood is distributed normally, but when they get up, it goes down from gravity. Yeah. It is about a 10-second lag before the nervous system can compensate for it. So most kids have about a 20 millimeter drop in blood pressure, if that makes sense to the audience. And but some of them have 40 millimeters and greater, and they become very symptomatic. Usually, if they get up, they feel something going on because it reduces brain flow. And if they wait, like you said, it goes away. Yeah. So that's a transient form of what I call orthostatic, meaning standing up intolerance. Yeah. In fact, it's extremely common and recognizable. It's called initial orthostatic hypotension, a horrible name. Yeah. Recognizably in about 50% of people.
Oh, wow.
For example, when you were young or even now, when you stood up fast, did you ever get dizzy?
Oh, ever? Yes.
I mean, you're in the second group now?
Yeah, I don't know where I am, but yes.
Fascinating, because only recently have there been articles dealing with aging, and I thought this never came back, but it does. And it can sort of morph its way into worse things.
Wow, interesting.
But that's not the topic of discussion. So single episode, usually not. Yeah. Infrequent episodes, usually I just tell them how to avoid it. It depends a little bit on the type of episode. Right, yeah. There's a type, usually when you have a faint, it follows a pattern of a fall in blood pressure followed by a fall in heart rate, and has somewhat of a gradual progression. And these others, they have almost no warning, and the heart rate essentially drops to zero or close to it.
Oh, gosh.
And, along with blood pressure. And they fall over. And it's called asystolic faint. Arguably, if you leave a fainter upright, they may become asystolic anyway. Right, yeah. But, or convulsive syncope, because they make little movements like a seizure.
Oh, gosh.
But it's not a seizure. Those who measure brain waves don't detect seizure activity.
Well, this is
that kind. Yeah. Has been treated in adults generally with a pacemaker, because the heart.
Gosh, right. Yeah.
And they crack their heads, and all sorts of injuries occur. Yeah. And more of our kids have required the same thing. Usually it's a matter of quality of life, unless they take up hang gliding or parachute jumping, and, or get injured too much in the bathroom.
So this is an educational tool. So what one message do you say very succinctly to doctors that are watching this right now? What do they need to know about fainting?
What do they need to know? The incidence of fainting is somewhere between 15 and 20% in the adolescent range. The lifetime incidence of one or more episodes is roughly 40%. And arguably fainting is normal. Normal things can do bad things to you, ruin your life. That's right, yeah. And it's really a question of quality of life, unless it's of cardiac origin. Right.
And the patients, you would say the same thing, that may be going through this? What unless
if they have recurrent syncope, then we make medical and other efforts to abolish this. If they have this asystolic fainting, which people should know about, and 20 years ago, we really didn't know about it, they may need more, and they need at least a better form of rhythm monitoring.
Right, yeah, all right. Doctor, thank you so much.
So, lastly,
yeah, you get your last word here.
The ER people are pretty well trained now. It's really developed very well, and they usually can take care of this stuff. But unusual things probably they don't see. I would say if you've gone to a reasonable ER where the person is comfortable, you don't have to have emergency admission. By the way, admissions usually result in absolutely no information at all. That's true. And you don't urgently have to see a cardiologist, but you probably should at some point.
All right, great. Great information, doctor. Thank you so much for your time.
You're very welcome.